Hi, my name is Erica Musi, and I am a sophomore in the School of Nursing at the University of Michigan. My clinical placement is at a local rehabilitation center, and I am going to present one of my patients to you. The patient interviewed is a 74-year-old Caucasian widowed male who was a medical researcher at the University of Michigan and a part-time salesman for video and electronics until his retirement 5 years ago. He is a long-term patient at a local rehabilitation facility, which is where he receives his usual care. He was admitted on July 5, 2007, and has a DNR status. The patient has two daughters who visit about once a month. The patient also has a son living in Wisconsin. The patient does not have a primary caretaker at home because he was widowed. He goes to church regularly and is affiliated with the Methodist religion. The patient's only reported stressors were the food served at the hospital and the desire to leave. The patient's chief complaint is a muscle spasm in his back. The patient reports the pain started in 1962 and the spasms occur a few times per year. When the spasm occurs, the patient says his pain is debilitating. The patient describes the pain as sharp and in the lower back and lasts about a week. The patient reports medication helps alleviate the pain and moving makes the pain worsen. The patient's present medical history includes back muscle spasms. The patient denies any psychological illnesses, but his chart states schizophrenia, post-traumatic stress disorder, and Alzheimer's are present. The patient's past medical history includes debility, hypertension, alcohol dependency, esophageal reflux, osteoarthritis, dementia, anemia, calcific uremic arteriolopathy, and acute renal failure. He had an upper GI endoscopy with the biopsy done. This is the patient's 5th hospitalization, but has refused all recommended surgeries for his back spasms. The patient has also been hospitalized for constipation and previous football injuries, including a fracture in the patella and tibia, though these injuries did not require surgery. The patient's immunizations are up to date, with the influenza and pneumonia vaccinations administered 2 months ago. The patient reported no known food or medical allergies, but is allergic to guinea pig and rabbit dander. Allergic reactions to these include asthma and rash. The patient is currently on several medications to treat pain, schizophrenia, incontinence, and hypertension. The patient was previously a smoker, and he smoked around 60 packs per year. The patient also reported alcohol consumption, which was an average of 6 to 8 ounces of hard liquor for 20 years. The patient regularly drinks coffee, consuming 2 to 3 8-ounce cups per day. The patient reports eating and sleeping regularly. He reports about 7 hours of sleep per night. The patient did not report any instances of cancer, cardiovascular disease, or psychiatric history in his family, but the patient's father had diabetes, which was his cause of death. Upon taking the patient's vitals, his pulse was found to be 70 beats per minute. His blood pressure was 130/78, and his respiratory rate was 16 breaths per minute. Because the patient was admitted for muscle spasms, I chose to perform a musculoskeletal examination. The patient's muscle mass and bone structure were normal. Upon assessment, the patient had full range of motion in shoulders, elbows, wrists, hips, knees, and ankles. However, the patient has very limited mobility in both left and right fingers due to osteoarthritis. The patient's left fingers were graded 0 out of 5 and right fingers were graded 3 out of 5 because the patient is experiencing decreased muscle grip strength. A contracture was noted in the patient's left hand and hyperextension of fingers was less than 30 degrees. No crepitus or warmth was found upon palpation. However, ecchymosis and erythema were noted bilaterally on the tibia. Muscle strength for deltoids, biceps, triceps, hip abductors and adductors, hamstring, quadriceps, and ankles was ranked 5 out of 5. Spinal assessment was deferred. While testing the range of motion, the patient experienced pain in his left knee related to a previous football injury. The patient tested positive for TMJ. Posture, gait, and scoliosis assessments were deferred. Patient reports when he moves around, his back pain ranks as 7 out of 10, and when he experiences a muscle spasm, the pain escalates to a 10 out of 10. The patient's back spasms interfere with his daily life. The patient reports he has osteoarthritis for 10 years and regularly experiences knee and back pain. The patient lives a sedentary lifestyle and requires a wheelchair for mobility. Before the patient was admitted, he had lifted weights and took walks to stay in shape. Because the patient has post-traumatic stress disorder, Alzheimer's, and schizophrenia, I chose to do a neurological assessment. Upon assessment, the cranial nerves 3 through 12 were grossly intact. The patient has equal pupil dilation. Cranial nerves 1 and 2 were deferred because of lack of equipment at the time of examination. However, the patient denies any difficulty smelling. Further, the patient reports he wears reading glasses. During the time of assessment, the patient was drowsy and oriented O times 2. He was alert in terms of person and place but could not identify the time. The Romberg test, gait, examination, and vibratory sensations were also deferred. As the exam progressed, the patient was unable to move his fingers on his right hand. The patient could not differentiate between sharp and dull pain bilaterally and in lower extremities, but was successfully able to feel both painful and dull sensations in upper extremities. The patient has intact proprioception, stereogenosis, and light touch abilities. In addition, the patient did not have a Babinski reflex or an ankle clonus. The patient scored a 22 out of 30 on the mini mental state exam. The patient's long-term memory is intact. However, his short-term memory is not fully intact because he was only able to report 2 of 3 words. The patient reports head injuries, including concussions during his football career, in high school and college. The patient denies any feelings of numbness, burning, or tingling, and loss of sensations. He has not experienced a loss of consciousness not related to a football injury or a loss of balance. Since the patient smoked for 20 years, I chose to do a respiratory assessment as a secondary review of systems. The New England Journal of Medicine's article, Global Effects of Smoking, of Quitting, and of Taxing Tobacco, indicates smoking causes more deaths than lung cancer. I would look for signs of emphysema, labored breathing, cyanosis, and crackles in the lung lobes. Further, I chose to do an abdominal assessment as evidenced by the patient's recent hospitalization for constipation. As stated by the Home Healthcare Nursing Journal's article, Evidence about the Prevention and Management of Constipation, it expresses ways to prevent constipation, including eliminating medications that cause constipation. I performed the abdominal exam and looked for swelling and tenderness in the abdominal area, as well as asking when his last bowel movement was.